Assalamu alaikum. Our lecture today will be about the sodium homeostasis. The objective of this lecture is to state the importance and the clinical significance, the role of sodium in the body, how the sodium is distributed between the intra and extracellular compartment, and we will discuss how the sodium is regulated, what are the mechanisms that maintain the level of sodium within the normal range, and we will correlate clinically with the state of hypo and hypernatremia and determine their causes. Sodium is the most abundant cation in the extracellular fluid, and from all of the cation, the sodium represents about 90% of them, of the extracellular cation. And because of this high percentage, 90% of the extracellular cation, so it is the main determinant of the osmolality of the plasma. Sodium concentration in the extracellular fluid is much more larger than its concentration inside the fluid, and the main supporting system that maintain the sodium in the extracellular fluid and potassium inside the cell is the active transport system, which is the sodium potassium ATPase that continuously push out or pump 3 sodium out of the cell and 2 potassium ions into the cell. Why this occurs? The purpose of this process is that if the sodium diffuse through the cell membrane, it will eventually reach equilibrium. And this is true for potassium. Potassium also will diffuse, and both of them reach equilibrium. This is very dangerous, and this must be prevented. And this can be prevented by the sodium potassium ATPase. Otherwise, sodium, when it flows inside the cell, it will followed by the water, leading to rupture of the cell membrane. So this process is very important to maintain each of these cations in its normal compartment. Sodium is very important in the body for many processes. It is important for maintenance of the fluid balance, for maintenance of the blood volume within the normal range, maintenance of blood pressure. It is important for the normal muscle function and nerve function. The sodium is closely linked with the concept of the osmolality. And always when we discuss the sodium, we must determine the role of sodium in maintaining the normal osmolality. The osmolality is determined by the number and not the size, the number of the particles per unit weight of water. So any solute that presented in large number will be a major contributor to the osmolality. And because sodium concentration is very high in the extracellular fluid, so it is considered as the main contributor to the osmolality of the blood. So any change in the sodium will affect the osmolality. The normal osmolality is about 295 millimole per liter. From this 295 millimole, about 270 millimole is by the sodium contribution. So the large contribution of sodium in maintaining the normal osmolality. How can we know the osmolality is normal or not in our body? The osmolality either can be measured by the osmometer or it can be calculated. The calculated osmolality is by a special equation in which we multiply 2 by the level of sodium plus 2 by the level of potassium plus the level of glucose in the blood plus the level of urea in the blood. The cause why we multiply each of the sodium and potassium by 2 is to double for the associated anion, for example, the chloride with these cation. Is the calculated osmolality easy to obtain? Yes, it is very easy through this equation. Is the calculated osmolality close to the measured osmolality? Yes, the answer is yes. The calculated is close to the measured osmolality, except in a certain condition when we have large concentration of the low molecular weight solute, for example, the ethanol, and in case we have this large amount of this particle in the circulation, they will contribute to the osmolality that is measured by the osmometer, but the ethanol will not be present in the we cannot calculate it, and because there is nothing that can represent it in the equation in the previous slide, the equation for the calculated osmolality, there is only we can measure the sodium, potassium, glucose, and urea. So any other analytes that are not present there will be measured by the measured osmolality but cannot be calculated. This results in a difference between the calculated and the measured osmolality. The measured osmolality will be higher than the calculated osmolality in this case, and the difference is called or cause an osmol gap. The osmolality is also this osmolality also applied for the urine, and we can measure it, or we can measure instead of it, we can measure the specific gravity, and this will represent the osmolality, or it may be close to the osmolality of the urine, and can be measured by urine dipstick, and it is accurate unless there is significant amount of glucose, protein, or contrast media that make a difference between the osmolality of the urine that is measured and the specific gravity. One of the important question is how the sodium is regulated within the normal range. This depends on the intake of water, the excretion of water, and the renal regulation of sodium. Water moves always in the same direction of sodium. The intake of water in response to thirst is changed according to change in the plasma osmolality, and the plasma osmolality depends largely on the level of sodium. Change in the level of sodium will change the plasma osmolality, and this will either stimulate or suppress the thirst center, and it will affect the intake of water. The other factor is the excretion of water. The excretion of water is usually controlled by the antidiuretic hormone from the hypothalamus pituitary release, and it will release in response to change either in the blood volume or secondary to change in the osmolality. So when we have change in the blood volume, for example, if we have decrease in the blood volume, this will stimulate the antidiuretic hormone, and the antidiuretic hormone act on the kidney and enhance the reabsorption of water, the retention of water, and this will lead to restoration of the blood volume. Or when you have a decrease or increase in the osmolality due, for example, increase in the level of the sodium, this will also enhance the production of the antidiuretic hormone, and this will enhance the retention of water by the kidney, and then the osmolality will return to normal. The normal level of sodium in the blood is 136 to 145 millimole per liter. The kidney have a great ability to excrete large amount of sodium, or it can reabsorb and conserve the sodium depending on the sodium content of both the extracellular fluid and also depending on the blood volume. All these can be controlled through the effect of the aldosterone, which is a melanocorticoid from the adrenal cortex, and through the angiotensin 2, and through also the atrial natriuretic peptide from the atrium. The major player in the homeostasis of sodium is the renin-angiotensin system, the glomerular filtration rate, and the atrial natriuretic peptide. What is the role of the renin-angiotensin-aldosterone system? We know that renin is the peptide secreted when there is decrease either in the supply or the level of sodium in the kidney, when the distal tubule of the kidney sense that there is low level of sodium delivered to it, or when there is decrease in the renal afferent arteriolar pressure. This will stimulate the renin, and the renin will act to convert the angiotensinogen in the plasma to angiotensin 1, then which will be converted to angiotensin 2 by the enzyme angiotensin converting enzyme. This angiotensin will stimulate the release of the aldosterone from the adrenal cortex, and aldosterone will promote the sodium reabsorption in the distal tubule. When sodium is reabsorbed, this will lead to water retention with the sodium. Sodium cannot enter the cell freely, so retention of sodium together with water will contribute to extracellular fluid volume expansion. So with this, how to change the homeostasis in this way? By the effect of renin-angiotensin system, the volume will return to its expanded way, and so we consider that the renin-angiotensin-aldosterone is the main regulatory mechanism for sodium excretion. The other important factor is the glomerular filtration rate. The rate of sodium excretion is usually related to the GFR. When the GFR decreases, this will lead to less sodium will be filtered and less will be excreted, and the vice versa is also correct. The other mechanism or the other peptide is the atrial natriuretic peptide, and this is secreted from the cardiocytes in the right atrium of the heart, and it enhances or increase the GFR, the glomerular filtration rate, and by doing that, it will increase the sodium excretion by the kidney. This figure will summarize how the sodium is regulated. In addition, the osmolality and the volume, all these are linked together. For example, in case of hypovolemia, in case we start from here, when we have hypovolemia, it will enhance the thirst center to increase the water intake, and also there will be less perfusion to the kidney. When there is less perfusion to the kidney, the renin will be activated, and later on by activating of the angiotensin gene, angiotensin 1, 2, and it will lead to production of aldosterone. Aldosterone act on the kidney to stimulate sodium retention. With sodium, water will enter and retain both the sodium and water retention occur, and this will lead to restoration of the normal volume of the blood. And in addition, when we have hyperosmolarity, when we have hypernatremia, increase in the level of sodium for whatever the cause, it will participate and contribute to increase in the level in the hyperosmolarity. This will stimulate the brain and release antidiuretic hormone. Antidiuretic hormone also will lead to water retention. Water retention will dilute by dilutional effect. It will return the level of the sodium to normal, and then the osmolarity also will return to its normal level. In case of hypervolemia, the anti-natriuretic peptide is released from the heart, and this will increase the sodium excretion by enhancing the GFR. When sodium is filtered, about 60 to 75% is reabsorbed back to the circulation. This occurs usually in the proximal convoluted tubule, and also part will be reabsorbed in the loop of Henle and the distal tubule by the effect of aldosterone, and it will be exchanged for potassium. What happens if someone ingests a quantity of sodium? This will lead to increase in the quantity of sodium in the extracellular fluid. What happens next? The level of sodium will increase in the plasma. This will affect the plasma tonicity or the plasma osmolality. If it increases, it will enhance the thirst center, leading to increase the amount of the water that is taken by ingested or absorbed. Later on it will be absorbed, and also this increase in the plasma sodium and the osmolality will lead to increase in the release of antidiuretic hormone. The antidiuretic hormone will lead to enhance or retain the water, increase the water that is reabsorbed by the kidney. And one of the bad effects of the increase in the plasma sodium is that the water will move out of the cell to maintain the electroneutrality, and later on, after the release of antidiuretic hormone and drinking large quantity of water, what happens is that there will be water retention, and both the plasma sodium and the plasma tonicity or the plasma osmolality will return to normal level, and at that state the water that was drained out of the cell will return back to inside the cell, and the homeostasis is achieved. One of the common findings in clinical practice is hyponatremia. So what is hyponatremia? It is decrease in the level of the blood plasma or serum sodium below the 135 millimole per liter. And when it decreased below 130, then it became clinically significant. This decrease occurs by three mechanisms. Whatever the cause, there is three mechanisms that will lead to the hyponatremia. Either we have increase in the sodium that is lost in the body from the body, or there is water retention and there will be dilutional effect of the water. The sodium will be distributed over a larger volume of water that is retained, leading to hyponatremia, or sometimes the hyponatremia may be secondary to water imbalance that occur secondary to other condition that will lead to movement of sodium and accompanied by water with it. These are main causes of the hyponatremia. We can either they have divided into increase in the sodium loss, or we have increase in the water retention, and the other cause is the water imbalance. When we have a decrease in the aldosterone level, in case of hypoadrenalism, whatever the cause, maybe autoimmune, maybe infection, maybe the tumor destructing the cell that produce aldosterone, there will be increase in the sodium that is lost. Why? Because normally aldosterone favor the sodium retention. If there is no aldosterone, then the sodium that is retained will be less, and there will be increase in the sodium that will be lost in the urine. Potassium deficiency also will lead to sodium loss because of the inverse relationship between the two ions in the renal tubule. When the serum potassium is low, the tubule will maintain or conserve the potassium and excrete sodium instead of it. So when we have potassium deficiency, this will lead to sodium deficiency. Ketonuria also will lead to loss of sodium with the ketones, and certain diuretic like the thiazide diuretic are a well-known cause of sodium loss. And when we have a prolonged vomiting or diarrhea, also this will lead to excessive loss of sodium. And in this condition, we can differentiate whether the loss is from the urinary system or from other system, because if the if the sodium is lost in the vomitus or in the stool in excessive amount in case of vomiting or diarrhea, in this condition, the urine sodium will be less than 20 millimole per day. In case of severe burn, this will lead to increase the amount of sodium that is lost from the skin. Other cause of hyponatremia is increase in the water retention, and in case of nephrotic syndrome and in case of hepatic cirrhosis. Water retention by dilutional effect, it will lead to hyponatremia. Because the sodium will be diluted in larger volume of fluid, and this will lead to hyponatremia. In case of nephrotic syndrome and hepatic cirrhosis, the mechanism is different in these two conditions. In nephrotic syndrome, there will be hypoalbuminemia. The protein will be also low. And in case of hepatic cirrhosis, because the liver is the site for the synthesis of albumin and most other protein, when there is cirrhosis or fibrosis of the liver, there will be decrease in the production of protein. And when there is decrease in the plasma protein, this will lead to decrease in the colloid osmotic pressure. And when this decrease, it will lead to intravascular fluid will migrate to the tissue, and the result is low plasma volume. And when there is low plasma volume, the antidiuretic hormone will be produced, and antidiuretic hormone normally it will cause fluid retention. When there is fluid retention, there will be dilution of the sodium and hyponatremia. And other compensatory mechanism can be seen in case of congestive heart failure. So in case in case of renal failure, there will be increase in the level of the urea, creatinine, and there will be hyponatremia. In case of nephrotic syndrome, there was decrease in the level of total protein, albumin, and there will be increase in the urine proteinuria. In addition, we will have hyponatremia. In case of hepatic cirrhosis, there will be abnormal liver function test in addition to hyponatremia. And the other mechanism that will lead to hyponatremia is the water imbalance. This water imbalance either occur in case of a chronic excessive water intake, and sometimes it can occur in case of syndrome of inappropriate antidiuretic hormone secretion, that in this condition antidiuretic hormone from its name is produced when the body really it doesn't need to be secreted in larger amount. It is inappropriately secreted, and this secretion is pathological and not secondary to a physiological need. This usually occurs secondary to pulmonary disease or malignancy or disease of the central nervous system, for example. And in case of infection, certain type of infection or trauma may lead to release of antidiuretic hormone inappropriately, and this is called a syndrome of inappropriate antidiuretic hormone. Pseudohyponatremia is a common finding in clinical practice, and it results secondary to, for example, there will be lysis of the RBC and release of sodium from the RBC. Sometimes hyponatremia can be categorized according to the state of the osmolality. Sometimes the patient have hyponatremia and normal osmolality. Sometimes hyponatremia, but he have hyperosmolality, and sometimes he have hyponatremia and sometimes hyperosmolality, and sometimes with hypoosmolality. For example, in multiple myeloma is an example of hyponatremia with normal osmolality, and this may be secondary to the presence of the gamma globulin. Gamma globulin is a cation, which is positive charge, so it will replace some of the sodium to maintain the electroneutrality. Overall, the patient is electroneutral in this compartment, but he have hyponatremia, and pseudohyponatremia is another cause of hyponatremia, but you have a normal osmolality when there is, for example, RBC lysis, whether in the blood sample, and this will lead to release of the water inside the cell together with the potassium and sodium, and the water concentration inside the RBC is usually lower than its concentration outside, and this will lead to a false decrease in the level of sodium and with a normal osmolality. While an example of hyponatremia with a high osmolality, for example, in case of diabetes, the blood glucose level will increase, and we say that the osmolality depends on the number of the particle or the number of the solute per unit of water. So, and in the calculated osmolality formula, we mentioned that it depends the four things that are that count in this equation is the level of sodium, the level of potassium, the level of glucose, and the level of urea. So any increase in any of these four may lead to increase in the osmolality. Example of this is when we have increase in the glucose in hyperglycemia and diabetes. This will lead to a hyponatremia, increase in the osmolality, and it will also be accompanied by hyponatremia, because the hyperosmolality, any hyperosmolality will lead to shifting of the cell from inside the cell to outside to the extracellular fluid, and this will lead to dilutional effect and hyponatremia. The symptoms of hyponatremia depend on the cause, and we say that the hyponatremia depend on the cause and depend on the level of the hyponatremia. If the level, usually we say that the normal is lower limit is 135. Anything below it is hyponatremia. If the symptom was between 125 to 130, there will be only GIT manifestation. If it is below 125, there will be neuropsychiatric manifestation in the form of muscle weakness, headache, nausea, vomiting, and lethargy. If it is below 120, we consider it as a medical emergency. The other abnormality is the hypernatremia. It is less common than hyponatremia. It occurs secondary to excessive loss of water relative to sodium loss. It means that both of them, the water and the sodium, is lost, but the water is lost in a larger quantity or larger proportion when you compare it to sodium. Or sometimes hypernatremia may occur secondary to decrease the water intake, or when there is increase in the intake of the sodium, or sometimes the sodium cannot be excreted, it is retained inside the body. So either there is a loss of water more than the loss of sodium from the body, or when the patient cannot take water, or when they have increased intake of sodium, there be hypernatremia, or sometimes it occurs secondary to retention of sodium. The intake is normal, but it cannot be excreted from the body. Hypernatremia usually occur in case of diabetes insipidus, when there is decrease in the antidiuretic hormone. In case of osmotic diuresis, secondary to anything that increase the osmolarity. In case of loss of the thirst, when there is defect in the thirst center, the patient cannot sense that he is in need of water, or sometimes when there is increase in the insensible loss of water from the skin. For example, in case of certain abnormality when there is increase in the respiratory rate, abnormal breathing lead to loss of large amount of water in this way, or sometimes when there is a loss of excessive amount of water from the skin secondary to burn, and when there is GIT loss of hypotonic fluid also will lead to hypernatremia, or when there is intake of excessive amount of the sodium. The diabetes insipidus that will lead to hypernatremia may be either due to nephrogenic diabetes insipidus, when the kidney cannot respond to the antidiuretic hormone, or when there is a decrease in the secretion in case of antidiuretic hormone in case of central diabetes insipidus. The excessive intake of sodium may be not just orally. Sometimes there will be excessive administration of hypertonic solution, IV fluid, that contain sodium, or sodium bicarb, or hypertonic dialysis solution. All of these contain large amount of sodium. So if the patient is taking large amount of this solution, it may end in hypernatremia. And in case the hypernatremia occurs in those persons who may be thirsty, but they are unable to ask for water. For example, some adults that have an altered mental state, so they cannot ask for water, or sometimes an infant who cannot represent their need to water. At this stage, they may develop hypernitremia. The hypernitremia lead to CNS manifestation because of the hyperosmolar state. The patient will be restless, there will be he is lethargic, or there will be altered mental state, muscle twitching, even fever, nausea and vomiting, and increase in thirst. If it is increased, we know that the upper normal level of the sodium is about 145 millimole per liter. If it is increased to more than 160 millimole per liter, then the mortality rate will be very high. Thank you.